that time of the season, and all through the house, everybody's doing something, playing ball outside, they're making music in the living room, a little mischief in the den. It's good to have everybody home again.
Well, good afternoon. I'd like to thank Lily and the organizers for having me to take part in your conference. I'm not sure if I have all the right answers, and I'm definitely not photogenic, so that's out. So, our topic for this afternoon is on the thyroid gland. I don't have a handout, but this will be a hands-on, simple lecture that will try to focus on thyroid disease as it affects our health. I'll also try to focus on the elderly patients, since our conference is really a geriatric conference. The thyroid gland, our objectives here for this talk is to understand basic thyroid physiology, and then I'll talk about simple thyroid function tests, how to interpret them. Then we will try to look at recognized patients with thyroid disease and a simple approach to management. Okay. So, as you all know, the thyroid gland is a very important gland. This is a gland that just sits in front of our trachea, but it basically regulates our whole body's metabolism. So it has systemic effects: liver, kidney, heart, brain, reproductive function. Okay. Now, it is important to understand how the thyroid gland is regulated, so that we can understand how these thyroid tests work, what they mean, and how we manage our patients with thyroid condition. So this is a slide showing the thyroid gland. This is the pituitary gland sitting right up here. Now, the thyroid gland makes thyroid hormones, and there's two hormones, T4 and T3. Okay, so this is what circulates in our blood. Now, what controls the thyroid gland is the pituitary gland. Okay, so this is the control tower. So the control tower makes a hormone which is called TSH, which means thyroid stimulating hormone. And the reason it's called thyroid stimulating hormone is because that's its function. It stimulates the thyroid gland. So this is under negative feedback regulation. So what this simply means is, if your thyroid gland makes a lot of thyroid hormone, the pituitary gland will say, whoa, there's too much, it's time to shut off. Okay? So if your thyroid hormone is high, the brain hormone will be low. On the other hand, if your thyroid hormone is low, that means if your thyroid is not working, then your brain hormone, which is TSH, should be high. Okay? So this rule applies for 90–95% of our patients, except if patients have underlying pituitary tumors, then that relationship does not apply. Okay? So based on this physiology, then we know there's an important interplay between the T4 and the TSH. Okay? So when we look at our patients, when we order our lab tests, one of the main things we look at is the TSH, or thyroid stimulating hormone. So normal range is 0.5 to 5, and so most patients who are euthyroid, again, that's where we expect to be. If somebody is hypothyroid, that means they don't make enough thyroid hormone, then the TSH goes up. Okay, so if you have a patient with a high TSH, that points towards hypothyroidism. If you have a suppressed TSH, then that points towards hyperthyroidism. Again, this is a generalization. This will work for 95% of our patients, except if they have tumors, except if they have certain drugs that can interfere with these tests. So time does not allow us to go into all these details, but this is the general principle. Okay. Now this is interactive, so if you have any questions, please feel free to just raise your hands and ask. So, looking at these two hormones in play, then we can look at patients looking at their T4 and TSH. So if somebody's hypothyroid, the T4 is low, the TSH goes up. If somebody's hyperthyroid, the T4 goes up, the TSH goes down. Okay? So it sounds fairly straightforward. So if somebody has a low T4 and the TSH is also low, what should you be thinking of? Anyone? Okay, so now, so we call this as primary hypo when the T4 is low and the TSH goes up. That means the thyroid is not working. But if your T4 is low and the TSH is also low, then what should that make you think of? Yeah. Okay, so that is what you should always be thinking of. So that's a very important general principle. Okay. Hypothyroid, not necessarily. Hypo, they may be cold, but not necessarily clammy. Okay. So if you look at this table just illustrates, I'm just going to illustrate this as an important point. So primary means problem in the thyroid. Central means problem in the control tower. Okay. So low T4, TSH should go up. Low T4, if the TSH does not go up, then you know something's wrong here because they should work accordingly. Okay? So this would be the main, this would be one thing, the only slide I'll focus on this point, then we'll talk about the general primary hypo or hyperthyroid. Okay. So who are the patients at risk for thyroid disease? This is by the American Thyroid Association. So patients who are newborn, babies, all of them get their cord TSH levels drawn to make sure they're not hypothyroid, congenital hypothyroidism. If patients have strong family history, this is again an autoimmune condition. So if you have a lot of family members with this, then you should be suspicious of this condition. Elderly patients, so as one gets older, the incidence goes higher. Postpartum women, this is a vulnerable period. So we usually say women who give birth, they feel down, you're just having the postpartum blues. Oftentimes they may have postpartum thyroid problems. Okay? And then if they have other autoimmune disease, if they have adrenal insufficiency, if they have type 1 diabetes, and this is also for if they have hyperlipidemia. Patients with high cholesterol, we'll go into that later. Oftentimes they may have low thyroid hormone levels also. Okay? So let's focus on hypothyroidism. So what we'll do is I'll talk about hypothyroidism, then we'll talk about hyperthyroidism, and then thyroid nodules. Okay? So this is looking at hypothyroidism, more than 10 million Americans affected. This is 10 times more common in women. So this is one of our autoimmune disease. As we get older, above 40 years, the incidence goes up over time. And if you look at statistics, high TSH, again, hypothyroidism occurs in 9.6, so almost 1 in 10 women between 45 to 54, and also in men, but much higher in women. Okay, and by the time we reach 60 in women, about 12% may have a high TSH. Okay, so this can occur in the young and also the less young. So 20, 45, 65. So this may be a slow, insidious process. Okay, so and you can see this same patient, TSH 1.5 normal, 7, 11. So over time, and they may or may not present with symptoms. Okay. Now, in terms of cause of low thyroid, most of the time this is from Hashimoto's. Again, this is an autoimmune condition. You have antibodies that attack your own thyroid gland, and then it stops working, your thyroid hormone drops. You can also have head and neck radiation, endemic areas, iodine deficiency, if they've had surgery, or certain drugs. Patients who are on lithium, so in your psychiatric unit, or if they have bipolar disorders, this is a strong predisposing factor for causing hypothyroidism. Another drug, patients with underlying heart disease are older patients who have atrial fibrillation. If they're on amiodarone, that's also a common drug that can cause thyroid dysfunction. Okay. So signs and symptoms, cold intolerance, constipation, lethargy, so things that slow down. Okay. They can also have thyroid enlargement, slow heart rate, irregular menses, elevated cholesterol. Okay, and we'll go back to that, and we'll go to that in a short while. Okay, so I put this slide. This is mixed edema coma. This is probably the most extreme end of hypothyroidism. So most patients, young patients, they tolerate low thyroid. This is the beauty of youth. You have resilience. You can adapt. as we get older, we may not be able to adapt to low thyroid hormone as much. So there are some patients that actually come in with mixed edema coma. This is not common, but this is the extreme case where you have low thyroid with mental status change. So oftentimes these patients end up in the intensive care. They may have mental status change, they have hypothermia, and they may have coma, seizures, and this may be a subtle finding. You may just say this is a failure to thrive when in fact, you need to check the thyroid, and maybe all the patient needs is thyroid hormone replacement. Okay. So goiter, this is an obvious case, big goiter. This is actually in an endemic area where you have iodine deficiency, and this is clearly 10 times bigger than normal. So we say goiter is anytime you feel the thyroid gland, because the thyroid gland normally we don't feel. Okay. So laboratory diagnosis, we talked about that earlier. So you can have patients with low thyroid hormone, so low T4, and the TSH goes up. So if you see this pattern, then that is consistent with hypothyroidism. Sometimes patients can have normal T4. So the thyroxine, the circulating hormone, is still normal, and yet the TSH goes up already. So this is early or mild thyroid failure. Okay. Now the reason why we may see this pattern is shown on this slide. This is the progression of mild thyroid failure. This is years, so over time. The blue line shows you the T4, what's made by the thyroid gland. The yellow line shows you TSH, what's made by the pituitary gland. So even if your thyroid hormone is still within the normal range, but as it drops, the first thing to give is the TSH, because the brain is much more sensitive. It says, oh, I'm seeing a little drop. We need to kick in and try to make more. Okay, so it's actually trying to tell the thyroid, lazy thyroid, make more hormone. Okay, and so the TSH may start to rise, and that's why some people with hypothyroidism, they form a goiter, because this is trying to ask this to work harder. So that's why there may be enlargement. Okay, so even if the T4 is low, is normal, if the TSH starts rising, that may be a sign of hypothyroidism already. So why is it important to treat this condition, even if it's mild? Well, in the first place, you did a test to find out is something going on, right? Well, the patient may be complaining of feeling tired. The patient may be saying, I'm feeling cold. I may be depressed. I don't feel as good. I can't lose weight. So these are some of the symptoms that they may present, okay? Another reason you may want to check the thyroid is if you have somebody with high cholesterol. A lot of our patients have underlying heart disease, high cholesterol levels. You start them on drug therapy, you give them Zocor, Pravachol, or whatever drug you want to use, and you find you can't normalize the cholesterol. Studies have shown that if you're hypothyroid, you don't clear the LDL or cholesterol particles as well. And so this is recommended by the American Thyroid Association, by the college and cardiologists, to also check thyroid levels in patients who are hypothyroid. Okay. And so so for these reasons, and to normalize cardiac function and to help depression. Okay? So we'll look at some of these factors. So these are some of the changes in lipid profile. Okay? Again, a lot of our elderly patients have heart condition, they have increased cholesterol. You say, well, let's see, maybe we can improve this profile. So patients who are hypothyroid, they tend to have higher cholesterol, higher LDL. Okay? And we know these are coronary risk factors. And again, that's because you don't clear the cholesterol particles as well when you're hypothyroid. Your metabolism is slower. On the other hand, if you're hyperthyroid, these numbers may be lower. Okay? So this is a study looking at about 268 patients. And this looks at patients with hypothyroidism and looks at their cholesterol profile. So out of all these patients, 56% or half of the patients have cholesterol above 200. Okay. If you look at triglycerides, that's a smaller percentage, about 1.5. In terms of mixed cholesterol and triglycerides, that's about a third of the patients. And only about 9% have normal lipid profile if you're hypothyroid. Okay. So, and there is a good correlation as your TSH goes up, 1.1. Again, normal is from 0.5 to 5. Okay, so 1.13, once you start going higher, 8.6, 22, 44, 63. As your TSH goes up, the LDL correspondingly goes up. Okay. Now let's look at it the other way around. Patients with high cholesterol, if you give thyroid hormones, what happens. So this looks at 3 different group of patients, 1, 2, 3. These are patients who have mild thyroid, TSH7, again normal let's say is up to 5, 18, and 154. So this is the severe hypothyroid group. The yellow bar shows the cholesterol before treatment. This is after treatment. Okay. The biggest difference is in the severe hypo. So their cholesterol here is almost 400. By giving thyroid hormone and correcting their thyroid dysfunction, cholesterol drops from 400 down to around 250. Okay, just by adding thyroid hormones.
How long is that time?
Once you get them euthyroid. So, pardon?
How long?
When you get them euthyroid, depends how fast you want to titrate your thyroid hormone to correct it. Okay, so this is TSH of 154 down to normal 1.8. Cholesterol drops from 400 down to 250 to 300 range. Okay, so you can look at it from both ends. Hypothyroid, higher cholesterol treat the thyroid, it can go down. Okay. Now, again, the cholesterol profile is just a presentation of cardiovascular disease. If you are hypothyroid, this can cause cardiomegaly. Studies have shown hypothyroid patients have higher incidence of coronary disease. Okay. This can also cause increased peripheral vascular resistance, diastolic hypertension. This can cause EKG changes. If they're bradycardic, they can have small voltages because of decreased systolic ejection. Okay. And because of decreased myocardial contractility. So the point here is effect of thyroid hormone on hypercholesterolemia in patients with mild thyroid failure. The decrease in total cholesterol achieved with thyroid hormone therapy in patients with hypothyroidism may be considered as an important disease in the cardiovascular arena in terms of favoring for treatment. Okay. Now, I'm showing you one slide looking at hypothyroidism and depression. Okay? So, if you look at depression, sleep disturbance, suicidal, weight change, delusions, constipation, decreased concentration, decreased mood, fatigue, sleep increase, symptoms of hypothyroidism, there is a big overlap. So, sometimes it's hard to tell if it's from the mind or whether it's really a metabolic dysfunction. So, you may have requested this test because the patient presents with these symptoms. So, even if their TSH is mildly off, I certainly think it's worth treating, and if they have symptomatic improvement. Now, again, you don't want to treat with thyroid hormones if their thyroid tests are normal, just to lose weight or to improve mood, because then that's not clinically indicated. Okay? So, now in terms of treatment, hypothyroidism, as this slide shows, there may be many causes, but the treatment is the same. Basically, you give thyroid hormones. Okay, so our goal is to normalize TSH regardless of the cause, whether the patient had surgery, whether they have autoimmune thyroiditis. Now, our treatment is to give whatever amount of thyroid hormone you need to normalize your levels. Anytime you make a dose adjustment, it takes about 6 weeks to equilibrate in the blood. Okay, so you can't start thyroid dose, check in a week, still off, adjust, because then you will all pile up and then you may over-treat the patient. Okay. Now, this says right dose of LT for several considerations. There are many different strengths from 25 to 300 micrograms. And the reason why they have so many strengths is because each person is different. For some, this is enough. For some, this may be too much. Okay. Now, very important, the standard dose is shown in this middle panel. That's about 75 to 125 micrograms. Okay, so in an otherwise healthy adult, that would be about the average range. Now, in elderly patients, so if somebody was 25 years old, 30, otherwise healthy, then I would go straight to the full replacement dose. Now, however, in our older patients, or if they have underlying heart disease, then you want to start low and go slow. Okay, and the reason for that is if they've not been exposed to thyroid hormone, when you start thyroid hormone, again, this regulates your metabolism. So if you jazz them up too much, the heart may not be able to keep up. So, patients who have hypothyroidism, their metabolism is slower, you start full dose, the heart starts pumping faster. This may unmask an underlying angina or heart disease, so you don't want to precipitate, coronary disease, have them have a heart attack by starting full blast high dose thyroid hormone or full dose thyroid hormone supplements. So in older patients, we tend to go with these, 0.025 or 0.05 milligrams, and then titrate gently. Okay? So again, the consideration, many hypothyroid patients first become symptomatic when they're older. Sedentary lifestyle may not induce exertional angina. If you start sudden full dose replacement, then you may unmask and the heart may not be able to keep up. So start low, go slow. Okay. So follow up. So once you start thyroid hormones, then you see the patient, you recheck the thyroid profile in about 6 weeks. If your TSH is still high, that means you're not reaching target, then you may need to go higher in the dose. If your TSH drops too low, then that means, we've gone overboard, so we need to back off. Okay? So another important thing, especially in our older patients, when you make a review of drugs, it's probably a laundry list. There's a long, long list of medication. So there are certain drugs you need to watch out for drug interaction. I'm just going to point out the key ones. Clearly, if they've had bowel surgery, they may not absorb the full dose. There are drugs that can interfere if they're on resin, Questran, cholestyramine, if they're on iron pills, if they're on antacids, if they're taking calcium supplements. Then you want to tell them to take it about 2 hours apart, because the iron, the calcium, they can bind your thyroid hormone and you may not absorb the dose that you prescribe. Okay? There's also several drugs that don't really affect thyroid function, but they affect the thyroid test. So if you have patients with seizures, if they're on Dilantin, if they're on TB medications, Tegretol, phenobarb, amiodarone, which is used for arrhythmia, that can interfere with your thyroid assay. Okay? Now, this slide shows take 1 pill twice a day, and don't I swallow it the first time. So it's very important to give the right instructions. So I'm not sure at the VA, in the past, let's say we wanted to give 0.175, we may not have that strength. So some patients may take 0.1 and then 3.075 to total 0.175, and then they get confused. So it's important to write down this is the amount you need to take, and then put down separate from other medications if you can, so you don't affect absorption. Because one of the more frustrating things when you're replacing thyroid hormone is you start this dose, one visit it's perfectly normal, the next visit it's off, then you say, what is your exact dose? It may be because of compliance, it may be because they're not taking the right dose that you thought they're taking. So it's always good to look at the bottle, make sure what you write down and what they're taking is the same thing. Okay? Now when we give thyroid hormones, we don't want to over-replace because of side effects. So you can make them hyperthyroid, thyrotoxicosis. Again, you can precipitate heart disease and very important, osteoporosis. So older patients, thinner bones, and if you give too much thyroid hormone, you increase their metabolism, you increase their bone turnover, and so there is an association with potential increase for bone loss and osteoporosis. So again, how do you know if you've given too much thyroid hormone? You look at the TSH. If it's below normal range, that means your pituitary gland is saying, whoa, there's too much, we need to back off. Okay? And again, osteoporosis, effects on hips, effects on bones. Studies have shown in women who get too much thyroid hormones, where their TSH becomes suppressed, there's a 12.8 decrease in bone density. Okay? So certainly the bone is dropping, you don't want to accelerate this process. Okay? So again, you use the right amount to keep the patient within the normal range. Okay. Any questions so far? No? So if not, we're going to switch gears and then talk about overactive thyroid gland. Okay? So what does this patient have? Okay, so this is staring at you. So this patient has eye stare. You can see the white of their eye. You can see the outline of their thyroid gland here. Okay, so clearly this patient has overactive thyroid gland. So whether they have Graves or other cause. So symptoms of hyper, this is now going to be the opposite. So things that make you go fast. Okay, so shortness of breath, fatigue. Fatigue is here. You may say, well, you have more thyroid hormone. Why should I be tired? Our body is not designed to run at 100 miles per hour. So if you go nonstop, your heart is always pounding at 100, 120 beats per minute, then your body will not be able to keep up. Okay, so fatigue, heat intolerance, hyperactive, irritability, mood changes, menstrual disturbance. So these are all things that make you go fast. Okay, speed. So clinical signs: goiter, they're hyperreflexic, they may have muscle weakness because their muscles are constantly on demand. They can have hypertension, tremor, and cardiac arrhythmia. Okay, because the heart cannot sustain the stimulation. Again, this is a goiter. So this is described as a symmetric goiter. This is much, much, much larger. This is easily 5 to 10 times normal thyroid gland. So what does this patient have? Okay. So you can see that somehow this gentleman was able to voluntarily propulse his eyes. So this is here. When he was young, he'd pop it out here, then he'd be able to just pop it in and out. So he actually didn't have Graves' disease. He was not hyperthyroid. He just was born with this. He was part of a circus act, and he was actually written up. A voluntary propulsion of the eyeballs, the double whammy syndrome. So most patients with hyperthyroidism, don't ask them to pop their eyes out. That won't happen. So again, if you have abnormal thyroid function test, you see lid retraction. Normally, you don't see the white of the eye. If you see that, then you say, we need to check this. Okay. So what does this gentleman have? Anyone? So we all know him. We see him every day, when he was president, in the news and television, and yet no one suspected he was hyperthyroid. Okay. So, but President Bush has hyperthyroidism. So his presentation was atrial fibrillation. So he just suddenly, and they rushed him to the hospital, checked his thyroid, and he was hyperthyroid. And no one knew it, no one ever noticed it. And in case you're not aware, his wife also is hyperthyroid. So Barbara Bush is also hyperthyroid. Yeah. So he didn't have exophthalmos. Barbara Bush has exophthalmos. Okay. So again, presentation may be silent. When we look at difference between signs and symptoms hyperthyroidism in the elderly, again, hyperadrenergic. In young patients, we see heat intolerance, muscle weakness, tachycardia, goiter. In our older patients, we may not see this classic symptom. So we actually have a term for it. We call it apathetic. Not because they're apathetic, but because there's lack of symptoms. So they may just present with tremors, muscle wasting, and you may say, oh, that's just old age, or they have Parkinson's. But it may be true hyperthyroidism. They may have muscle wasting, failure to thrive, and they may just have atrial fibrillation. So all patients who have underlying atrial fibrillation, it's important to check the thyroid. Okay. Again, when you're hyperthyroid, effects on bone, and it can affect your heart, increase heart rate, and increase risk of atrial fibrillation. This has been studied out. This is a publication, 1994, New England Journal. This looks at low serum TSH as a risk factor for atrial fibrillation in older patients. So what they did was they looked at patients, and these are patients who were 60 years of age or older, and they look at their TSH. So that was the only variable. TSH, low, hyperthyroidism. And those that had low TSH had the 3-fold higher incidence of atrial fibrillation compared to those that had normal TSH, even if their T4 was normal. So the fact that the pituitary senses more thyroid hormone, that means the heart may be sensing more thyroid hormone. Okay. So in this population, you want to be more aggressive. So hyperthyroidism causes, the most common is Graves' disease. This is autoimmune. So if you have antibodies that trigger your thyroid gland. You can also have thyroiditis, which is usually a viral infection causing inflammation. This is usually transient. Thyroid hormones go up, and then as the inflammation subsides, then it goes back. Most common is exogenous. You give them too much thyroid hormone. They can have toxic nodular goiter, so lumps and bumps that become autonomous. So these are by far the most common. Less common would be brain tumors that make too much TSH. Okay, but that is also a consideration. Okay. Now, hyperthyroidism, I'm using Graves' disease as the most common example. High T4, low TSH. Okay. So what's your next step when you see somebody with a high T4, low TSH? Again, I'm sorry. Go ahead. Yeah. So again, hyperthyroidism, there's a laundry list here. So then you say, how do I know which is the cause? So what's your next step? Okay. So unlike hypothyroidism, where many causes, one treatment, hyperthyroidism, you need to know the cause because the treatment is going to be based on what the cause is. Okay. So what's the next step you can do? Well, the next step you can do is to take a picture. Okay. So you can order, this test is called the 24-hour iodine uptake. So you can give a patient, an iodine capsule and then let him come back, and then you take a picture of the thyroid gland. And then with that picture, you can tell one from the other. Okay? So let's look at some pictures. This is a picture of the thyroid gland. So when you give iodine, this concentrates on the thyroid gland. So this is the right lobe, the left lobe. Somebody who has Graves' disease, both glands are hot. So the whole picture shows this is hot. Somebody who has a nodule, one lump, so it only concentrates on the lump and the rest of the gland doesn't pick it up. So this is a hot nodule. This is a Graves' gland where both glands light up like a light bulb. Okay? And then this one, you really don't see anything. That is a patient who has thyroiditis or inflammation. They have a viral infection, they have fever, they have sore throat, the thyroid hormone releases, but the thyroid doesn't work because it's sick. There's an inflammation. So when you take a picture, you don't see the thyroid gland. So with this picture, it's very important and it tells you one from the other. Okay. So the name of the test again is called the radioactive iodine uptake. So this is requested in the nuclear medicine department. Okay. Okay, let us just look at one case. This is a 37-year-old male, comes in fatigued, nervous, headache, heat intolerance, 15-pound weight loss. He is thin, heart rate 120. He has tremors, he has a goiter. Thyroid hormone normal is 4 to 10. Patient's is 17. So again, it's high. So he's hyperthyroid clinically and biochemically. If you look at the TSH is 5. Normal is 0.35 to 5.5. So what should be going through your mind? So again, hyperthyroidism, high T4. What should the TSH be? Again. So it should be low, right? Again, feedback. High T4, the brain says, whoa, there's too much, I need to shut off. Now, if you see this pattern where the brain doesn't shut off, you say, well, something is wrong. So it may be that the problem is not here, the problem may be up here. Okay? So it turns out this patient actually had a brain tumor. So this is a tumor in the gland that makes TSH. So it's actually a tumor where this gland makes too much hormone that stimulates your thyroid gland. Okay? Whereas Graves' disease is where your thyroid, the problem is here, you make the thyroid hormone and the brain responds by shutting off. That's a normal response. This is abnormal. Okay? So again, that's why I point out hyperthyroidism treatment should be directed at the cause. If somebody is on too much thyroid hormone, you need to back off. If there's a brain tumor, you need surgery. If there's inflammation, it's supportive. And if they have autonomous nodule or Graves, then it's either surgery or radioactive iodine. Okay? Questions? Is it clear? Okay. So another important thing, we talk about TSH. If it's low, then we think of hyper. This is important. Low serum TSH in older patients without hyper. Okay. Again, in older patients, the TSH, the pituitary gland may not be as robust. So if your TSH, again, normal is 0.5 to 5. Some patients may be 0.4, 0.3. That may still be a normal variant for older patients. So you have to look at the clinical pictures. You need to look at their thyroid hormone levels also. Okay. So treatment, the most common again is Graves' disease. So we usually don't recommend surgery unless we think there's cancer. Most patients who have overactive gland, it's unlikely that they have any cancer. Okay? Because most cancers, they don't work, whereas overactive, they're functioning. Okay? So radioactive iodine, the one we used to take a picture, we can give a higher dose to ablate the thyroid gland, make the goiter shrink, make the thyroid hormone go down. Okay? And then when they're hyperthyroid, you want to use beta blockers, propranolol, atenolol, to block the effect of thyroid hormone until these treatments kick in. Okay? So this is really more for symptom control while you're waiting for the radioactive iodine or surgery to kick in. Okay? So I mentioned this thyroid storm. This is the opposite of mixed edema coma in hypothyroid. This is the extreme case of hyperthyroidism. Okay? I bring this up because, again, younger people, they can tolerate high thyroid hormones. In older patients, our body may not be able to keep up, so there's a higher chance of more life-threatening complications. There's really no criteria. This is a syndrome, so this is a clinical picture. So these are patients who are hyperthyroid who come in, they can have mental status change, severe tachycardia, they can have fever, hyperthermia, and cardiac arrhythmias, or they can come in congestive heart failure. So these patients you need to treat more aggressively and try to lower their thyroid hormones faster, in a faster manner. Okay? So this is called thyroid storm, which is the extreme manifestation of hyperthyroidism. Okay? So the last few slides we will focus on thyroid nodules. Again, there's always concern for cancer whenever you have a lump in the thyroid gland. Incidence may also increase as we get older. As we get older, there's higher chance of multiple nodules also. Okay? So how do we approach thyroid nodules? Again, the most important is by clinical exam, because unless you feel the nodule, you wouldn't pursue the workup. One way we approach this is you can order a picture. So the same as for the hyperthyroidism, you can order a scan. If this is the nodule, you can see this lights up. So this is a hot nodule. So hot nodule functioning. A hot nodule is less worrisome for cancer. The incidence is less than 1%. Okay, one rule in medicine, we say never, because there's always exceptions. But almost always not cancer. A nodule can be cold. So again, this is the normal thyroid tissue. This nodule is not working. It doesn't trap or take the radioactive iodine. This one is regarded as more suspicious. Okay? This is called warm. You really don't see any difference, but the investigator put a circle because that's where the nodule is felt. That means the intensity is iso-intense to the neighboring tissue. Okay, so this is regarded as if it were a cold nodule. So whenever you have a nodule, the next step is, the recommendation is really to go with the biopsy. Okay. All right. So again, if you have a cold nodule, this needs further workup, and cold nodule, the next step is a thyroid needle biopsy. And this is done in an office setting, takes about 10-15 minutes. Clean the area, local anesthesia. We do several needle passes directed at the nodule to aspirate cells, and then the pathologist reviews the slide to make sure if there is or there is no cancer. So if you have a thyroid nodule, you get a biopsy, the results will show either it's cancer. The treatment for that would be surgery and radioactive iodine to kill whatever cells are left. It can be suspicious, it can be benign. If it's benign, then you can opt to follow it over time, or you can decide to give them thyroid hormones to try to suppress it. If it's inadequate, then you may need to rebiopsy. If it's indeterminate or not clear, another approach is then to go back and do a scan. If it shows it's a hot nodule, then you're not as worried. If it shows it's a cold nodule, either you want to rebiopsy or surgery. But the key thing is to follow over time. Make sure this is not growing or changing. Okay? Okay. So to summarize, primary care physician has a very important role in treating patients either with hypo or hyperthyroidism. So it's important to know the risk factors, and if these patients have it or by their symptoms, then you would consider the diagnosis and then request the appropriate test. And again, the thyroid function test, TSH, T4 are your main initial test. And you want to refer when appropriate. These are usually if patients are pregnant, if you're using high-dose thyroid hormones and you can't correct it, if they have a large goiter, despite giving them thyroid hormone, it continues to grow. So these may be some reasons to refer. Again, very important, over and under replacement. When they're hyperthyroid, when they're hypothyroid, our goal is to keep them in range. If you give too much thyroid hormone, you can cause more harm, osteoporosis, cardiac arrhythmia, older patients, again, they have heart disease, angina, arrhythmia, so you don't want to push them towards this end. Under replacement, if you don't get enough thyroid hormones, they remain hypothyroid, they remain symptomatic. You have increased lipids, decreased cardiac function, also increased risk for cardiovascular disease. So why do we try to correct all these variables? As this cartoon shows, our patients, we're all, the longevity is longer and longer. So as this slide shows, I'm still trying to figure out what I want to be when I grow up. So hopefully we'll be able to provide our patients with a long outlook in life. Questions? Anyone?
We don't have any questions for Dr. Lee.
Okay.
He answered all the
I don't know about that. So
We had a doctor,
go ahead.
We had a doctor at Charles School, and it was cold up in Omaha.
Mm-hmm.
Cold. He never wore a top
So he was hyperthyroid? Hyper. So again, the presentation can be very subtle. We always have our classic, picture of classic hypo or hyper. Again, keep in mind with our older patients, they don't present the classical presentation. So just like President Bush presented with arrhythmia, there are some patients who may end up in the psych ward feeling depressed, but it may be just that we need to check for their thyroid levels. So, go ahead, sir.
This is an aside. It's not a question, but I'd like you to answer it anyway.
Uh-huh.
During the Gulf War, when President Bush was in office, there were a number of news broadcasts coming out because at one time he was taken and he had his annual physical. And at that point in time, one of the little blurbs in the paper probably said that he had been tested, they had tested his lithium and it was normal. I had always assumed that was because he was depressed. They were probably giving him lithium, and I may be wrong. Do they normally test for lithium? Now that you've mentioned he's hyperthyroid, wouldn't that have had a contra effect also?
Now, if somebody's so I'm not aware if he's on lithium or not, but if somebody is on lithium, lithium has a funny effect on thyroid hormones. Somebody who's on lithium, the incidence is clearly much higher in terms of hypothyroidism, so it's actually low. There are some case reports of lithium causing hyperthyroidism. The way lithium works is it blocks the release of thyroid hormone from your gland. So there are several stages in thyroid hormone synthesis. The final step is to release it from the thyroid gland to circulation. If somebody is on lithium, it can block the release, and so patients are hypothyroid with a goiter. So I'm not sure if we can say lithium is the cause for his hyperthyroidism or not.
I assumed
Yeah.
he was depressed at the time. I mean, I was depressed and I would have him called up.
It's actually interesting. The cause of hyperthyroidism is hard to tell. They've actually even tested the waters, White House, because both the First Lady and President Bush had so they're trying to find out what is the cause. It seems like if you have political ambitions, you have to be careful. Tipper Gore also has a thyroid nodule, so it seems to concentrate. So okay. If there are no questions, thank you for your time.
Well, it's that time of the season, and all through the house